Ma présentation a pour titre Disparités, politique de services de santé et aînés francophones en situation minoritaire au Canada. The objective of this research that we conducted was to examine the contribution of policies and policy regimes in furthering or reducing health disparities between Canadian Francophone minority older adults and the general Canadian population of seniors. Some of the contextual approaches guiding our research, the constitutional framework for official languages in Canada. One thing we need to know is that when we talk about official language minorities, we are talking about Francophones outside of Quebec and Anglophones in Quebec. In this case, this study focuses on Francophones outside of Quebec. And so in a country like Canada with two official languages, we have a framework that enables the provision of services in those two languages depending on the context of each province. The other framework was the World Health Organization's conceptual framework for action on the social determinants of health, Rossell's framework of criteria for evaluating public policies. And there are some of the criteria there, as we'll come back to that later on. So we developed a framework, an overarching framework for this research, and you can see how we have four circles. The orange one is the Anderson model that we use. We went from the Anderson model to a population health approach, to the WHO's framework, and finally to the policy framework of Rossell. Our population, if you are age 50 plus, you would be considered older adult in our research. Why did we do that? We do that so that we could enable analysis by age group from 50 to 64 and from 65 and older. And so from 50 to 64, we were able to discriminate, to find some differences that I'm not able to highlight in this study. And so you had to be age 50 and plus, speak French as language of conversation, or most language spoken at home, or be interviewed in French, or speak French as your first official language. The sources. We used two Statistics Canada surveys. The first one was the 2006 post-census survey on the vitality of official language minorities. The second one was the Canadian Community Health Surveys of 2007, and we used multiple linear regression analysis. And in our study, in our multivariable analysis, we used self-rated health as our dependent variable, coded as followed: 1 for excellent and 5 for poor. We also conducted a feedback from minority Francophone community members on the findings. Here is, you can see that the size of our samples for the SVLM, the post-census survey, over 8,000, and for the CCHS we have 24,000 and plus respondents. Here is the WHO's framework that I alluded to, and what I want to point out here is how you'll go from the left hand, the socio-economic and political context, pay attention to social policies, public policies, and you move to the right, and ultimately to impact on equity in health and well-being. And so you have at the bottom two blue rectangles. One is the structural determinants, social determinants of health inequities, and you have the intermediary determinants of the social determinants of health. With regards to the policy analysis, which is really what this presentation is about, we had an in-depth look at provincial health services policies or legislation. with focus on the Saskatchewan government French language services policy. Why? Because that's where we reside, and we wanted, in a way it was convenient, but also we could have access to the Francophone population right there and see the impact of the policy on their lives. We did a policy evaluation based on the criteria I mentioned above from Rossell's framework. It was important for us to look at equity, efficiency, effectiveness, health impact. This is whether the policy had an impact on health and political feasibility. It was also important to see whether those policies adopted a hands-off or hands-on approach. Here is Rossell framework, and nothing really important for me to point out here except the criteria I mentioned. And so what were the findings? Now, when I'm talking about findings, I'm talking about both findings from the statistical analysis as well as feedback from community. And so what happened, what we discovered was that minority Francophone older adults consistently rated their health more poorly than their counterparts in the general population. So if we're talking about disparities, you can already see a hint about that disparity right there. We also noticed that higher concentration of Francophone community was associated with poorer self-rated health. This is generally shocking because why? Normally in places of higher concentration, you expect, given the fact that you have health services readily available, health institutions, health professionals available, you expect people to readily have access to those services and be in better health. In the case of minority Francophones, we're talking about an older population that generally moves to urban centers because of health issues. That's why you see that higher concentration of Francophone community was associated with poorer self-rated health. Also, minority Francophone older adults' weak sense of belonging. We noticed that they tended to have a weak sense of belonging to their Francophone community. In other words, you can see through this finding the effect maybe of assimilation, how over time they lose a strong sense of belonging to their community. Also, they were less likely than their Anglophone counterparts in Quebec, than Anglophones in Quebec, to request services in their language. In other words, Anglophone older adults in Quebec are more likely to request and demand services in English compared to Francophones outside of Quebec. Again, there we can see the impact of assimilation as stated further down. Not known from this study, though, is the extent to which official language minority status alone is associated to self-rated health. And why? The title of this panel is important in this regard. This certainly exposes one of the challenges in minority research, in that in those surveys, for example, Statistics Canada surveys, what they generally do, they include in the study the percentage of a minority as in the general population. And so that percentage being low, we had in our study a low percentage of official language minorities, and this had an impact on being able to conduct statistical analysis at the multivariable level. And so the other finding was that feedback from Francophone community members emphasized, as I said earlier, the role of assimilation and structural inequities as contributing to health disparities and the low vitality of their communities. Now, this is a finding from the policy analysis. You can see in this table that we have New Brunswick at the top, and this is really ranked depending on the ability of policies in each of these provinces or territories to be able to impact the health of Francophone older adults or Anglophones in the case of Quebec. And so New Brunswick, for example, being officially bilingual, ranks higher. We have Quebec and Manitoba, for example, and Ontario. We have constitutional bilingualism that enables them to rank higher because of, what those constitutionally based expectations have on those populations in those provinces. Low, in the middle, you'll see Saskatchewan and Alberta. They rank quite low when we're talking about just provinces. Now, we need to understand Canada's policy environment as a bilingual country. We have the Constitutional Act of 1867, the Official Languages Act of both 69 and amended 88, and the Charter of Rights and Freedom. These set parameters for Canada's linguistic duality. However, Canada is a federation with provincial jurisdictions and their own policy regimes, and this is important. This means that it is not because Canada as a country is bilingual that every province is bilingual. No. Every province has not only its own regime at that level, but with regards to other aspects of their lives as well. And these policy regimes are what play a greater role in shaping the lives of Francophones outside of Quebec. It is not the geography, because we know that there are scattered Francophones outside of Quebec. Yes, it plays a role, but more than geography, it is more than concentration, in fact, it is the policy regime. Inequitable policies, then, create structural and systemic social inequities that further health disparities. In provinces with less prescriptive policies, minority Francophones struggle significantly to access health services in French. And so policies and policy regimes have a major impact on their vitality, sense of belonging, and social capital, which in turn impact their access to health services. And so, as we discussed, we know that in Canada there is a debate over whether Canada has reached what they call a demand or supply equilibrium with regards to services to minority Francophones Canadians. A study suggested that that was the case. We in our studies say, well, it may be the case, but we have a responsibility in Canada to support minorities, to invest in minorities, and to ensure that everyone, regardless of race, gender, and so on, has access to health services. There are examples worldwide. In Wales, for example, there's greater increasing government action so that services can be accessed by those who speak the Welsh language. And so some of the weaknesses of this study, we were not able, as I mentioned earlier, to show the ways in which official language minority status alone, affects cell-rated health. But also, we weren't able to discriminate with regards to policies provincially or even territorially. In conclusion, what we are urging in this study is more aggressive, hands-on, equitable policies for governments. More concerted efforts. What we notice in Canada, you have the federal level, provincial level, and no one seems to be talking to another. And so more concerted efforts are needed by federal and provincial or territorial governments, reinforcing health disparities. We need that in order to address those social inequalities that reinforce health disparities. This will help legitimize health services in French for minority Francophones, reduce the disparity gap, and hopefully improve their health. Thank you very much.